Good evening, everyone. I'm Tony Segreto, and once again, so honored to be your moderator for tonight's In the Know Town Hall. We welcome all of you. Tonight, we will focus on a critically important topic and one that's touched so many people. We're talking about managing type 2 diabetes. You know, type 2 is far and away the most common form of diabetes, accounting for about 95% of all adult cases. While it can develop at any age, type 2 diabetes, as most of you know, most often strikes people who are middle-aged and older. It's a disease that can wreak havoc on the body even before patients are diagnosed. That's why we need to be aware of all of the symptoms and all of the risk factors that come along with it. That's why tonight we're going to examine those factors. We're going to discuss the best methods of prevention and the steps that we can all take to manage type 2 diabetes if we or someone we love are diagnosed with this disorder. Thankfully, we have an incredible team of physicians at UHealth who are continually finding new ways to manage type 2 diabetes. And tonight, they're going to help us explore all of the new innovations in treatment and in care. And all I can tell you tonight, ladies and gentlemen, we have done many of these in the nose. Tonight's doctor lineup is the wow factor. It's led by Dr. Ernesto Bernal Mizrahi, the chief of the Division of Endocrinology, Diabetes, and Metabolism at the Miller School of Medicine, and the deputy director of beta cell biology and signal transduction at the Diabetes Research Institute. He'll be joined by Dr. Rajesh Garg, the director of the Comprehensive Diabetes Center at the Miller School, Dr. Justin Townsend, who's an assistant professor in clinical ophthalmology at Bascom Palmer Eye Institute, Dr. Michelle Perlman, an associate professor in digestive and liver disease in the Department of Medicine and a physician nutrition specialist. Dr. Jason Levine, who's an assistant professor in clinical medicine and a podiatric surgeon. And last but certainly not least, Dr. Alessia Fernoni, chief of the Katz Family Department of Nephrology and Hypertension and director of the Peggy and Harold Katz Family Drug Discovery Center in the Division of Nephrology and Hypertension. Needless to say, as you can see, this is truly a world-class group of experts, and we are so honored to have them with us tonight. Now, before we get started, let's go over how you can participate in tonight's conversation. After Dr. Mizrahi delivers his opening remarks, all panelists will answer the questions that you've submitted over the last few days, but you'll also have the opportunity to submit questions during this program. For those of you who have been with us before, you know the drill. For those of you who are new, at the bottom of your screen, you're going to see a Q&A feature. That's where you will submit your questions. And a reminder to all of you, those questions will be submitted anonymously, and we promise we are going to get to as many of them as we possibly can. We have a lot on our table tonight, so we're going to get started right away. It is my honor and my pleasure to introduce Dr. Mizrahi. Doctor, thank you so much for taking the time to be with us tonight.
Good evening, and thank you, Tony. It's such a pleasure to be here with you. Particularly proud to represent the Division of Endocrinology, Diabetes, and Metabolism at the Miller School. It is a superbly talented group, and we're happy to be here tonight with our colleagues from other departments to advance the health of our community when it comes to managing type 2 diabetes. We know that as many as 30 million Americans have type 2 diabetes, but more importantly, there is another 7 million more that may be undiagnosed, and that's one of the key points to know. Type 2 diabetes disrupts the body's ability to control blood sugars and affect critical function, including the circulatory and cardiovascular system, vision, and kidney functions. So there are many risk factors that include family history of diabetes, being overweight, lack of physical activity, and health problems such as high blood pressure. Tonight, we're going to take a look at the best ways to manage type 2 diabetes. We have a wonderful panel assembled who can share their expertise on every component of this debilitating disease. My expertise is in managing both type 1 and type 2 diabetes and in developing new treatments and experimental therapies. Dr. Rajesh Garg also specializes in management of this disease and providing patients with the most effective treatments to keep diabetes under control. Diabetes can also lead to serious visual problems, and it is the leading cause of blindness in this country. That's why we have Dr. Justin Townsend, who is an expert on eye-related issues caused by diabetes and what can be done to prevent them. Eating, as you know, is another key element we'll focus tonight on, and Dr. Michelle Perlman will talk to us about nutrition and understanding what the best diets are to keep your health well managed. We're also going to talk about proper food care. This is one of the major issues in diabetes, and Dr. Jason Levine will explain why food and alcohol care are so important and the steps we can take to avoid potentially serious issues in this area. We're also joined by Dr. Alessia Fornoni, who is the chief of the Division of Nephrology and an expert on how diabetes affects the kidneys. And her group is also developing cutting-edge drug treatments in this field. In summary, these are some of the best experts in the field, and I hope tonight we will be able to answer your questions. Tony, back to you.
Dr. Mizrahi, thank you so much. It really is a star-studded field. All right, it's time now to go to our questions. We have so many of them. We want to make sure we get to them right away. And Dr. Perlman, we're going to kick it off with you. And the first question that was submitted over the last couple of days is, what type of diet is recommended to manage type 2 diabetes?
It's such a loaded question, Tony. There's really no answer, and that's not a cop-out. There really is no one answer. I really try not to use the word diet. It often signifies a very short-term plan that's very restrictive and just not sustainable. Most people are able to follow a fad diet for a short period of time, but really the challenge is maintaining that weight loss. And the dreaded yo-yo effect and that vicious cycle is a true phenomenon and can really cause long-lasting damage. So really the optimal nutrition plan for a diabetic really depends on a variety of factors. That includes how well someone's blood sugars are controlled, whether they have certain medical problems like diabetic nephropathy, gastroparesis, what are their food preferences, what are their food sensitivities or allergies, whether or not they need to gain, lose, or maintain their weight. Now, when you look at the American Diabetes Association and when you look at more evidence-based medicine nutrition research that has been done, the data suggests that diets that kind of go along with the Mediterranean type diet, the DASH diet, Ornish diet, which is a low-fat kind of plant-based diet, they all have shown improvement in glycemic control and lowering the need for certain medications.
Dr. Perlman, before you go, there are so many food items out there that talk about not spiking the glycemic index. How trustworthy are they?
It's why I have job security, shall we say, Tony. The health food industry is $1 billion industry. And what I tell people all the time is that if we're truly helpful for people, then we wouldn't have more chronic illness today than we've ever had. And the prevalence of obesity would be going down and not staying the same over the past 20 years. And when you actually look at the prevalence of morbid obesity, so those with a BMI over 40, particularly in women, that is actually going up. And so the glycemic index, it's really difficult to interpret that, and we'll kind of talk more about that later in the hour. But really the quote unquote health foods and the artificial sweeteners and everything really are not a good option.
Thank you, Dr. Perlman. Dr. Mizrahi, you touched on this in your opening statements. The question is, who should be tested for diabetes?
Yeah, as I mentioned, there are 7 million individuals who have diabetes and don't know it. So the American Diabetes Association has developed a set of criteria to screen individuals for diabetes, and those individuals who are overweight or obese, and in addition to that, have first-degree relative with diabetes or belong to high-risk ethnic groups like African American, Latino, Native American, or Asian American should be also included. Also, individuals who are overweight and have history of cardiovascular disease, hypertension, women with polycystic ovary syndrome, which is another entity that can be associated with diabetes, or for all other patients, testing should be start at age 45, and then they should also repeat it at a minimum of every 3-year interval. So all these are individuals who should be tested, and in addition to that, Patients with prediabetes, which we can talk later, also need to be tested every year to see if they are progressing to diabetes. So all those are criteria that the American Diabetes Association has proposed to screen patients for diabetes.
Thank you, Doctor. Dr. Garg, welcome. We have a question for you here. Can you do something to cure my type 2 diabetes? I have heard that gastric bypass surgery can actually help.
All right. So there are a lot of myths, misconceptions about diabetes. So let me tell you that diabetes is not just eating or unhealthy lifestyle. It is also something genetic. So you were born with some specific set of genes that made you more prone to get diabetes than the other people. So you will see a lot of people have someone maybe 200 pounds, 300 pounds, but will never get diabetes. So this means there is something underlying predisposition to get diabetes. And what I'm trying to convey is underlying disease is going to stay. So it may be that temporarily you will not need any medications, but once you have diabetes, it's going to stay in some form or the other. You may not need medications for several years if you can lose weight, like getting gastric bypass, but eventually it's going to catch up. So one has to stick to that healthy lifestyle and do everything that you can. But I will not advise to consider that it is cured.
And what about the gastric bypass?
Even after gastric bypass, initially there was some data that 80% patients don't need any medication after 1 year. But when we have followed them, we know that almost 70% need medication after 5 years. So we know that the underlying defect, which is making people prone to get diabetes, some people, those who have type 2 diabetes, that's going to be there even after gastric bypass. So over time, they are going to need medication. So one has to be careful about if you are going for a gastric bypass in the hope that you will be cured, please don't think that way. It will make it easier to control your diabetes. It will improve your health, but that's not just one reason, curing your type 2 diabetes. That's not the reason.
Thank you, Dr. Garg. Dr. Fornoni, welcome. It's nice to have you with us as well. How do I find out if diabetes affects my kidneys? And would it affect one kidney or would it affect both kidneys?
Thank you, Tony. Diabetes is a systemic illness, meaning what it means is that it affects the entire body. And as Dr. Bernard Mizrachi mentioned, the diabetes can affect different organs, including the kidney. So usually because it's a disease that affects the entire body, both kidneys are affected. Very often, a patient coming to the clinic and asking, is it one kidney, two kidney? It is both, no? Luckily, we're born with two kidneys. We can donate a kidney and the other one is actually there and compensate. But because the diabetes is a disease that affects the entire body, both kidneys are affected. So how do you find out whether, if you have long history of diabetes, whether you have diabetic nephropathy? That's how we call it, diabetic kidney disease, the involvement of the kidney in the setting of diabetes. It is very imperative that when you go to your PCP for your annual, or you go to your endocrinologist following your diabetes, every year you get tested the urine to check whether you're spilling albumin. The kidney is like a filter. So in diabetes, this filter gets loose and the protein tend to pass from the bladder to the urine. And that's how we monitor the appearance of the first initial damage of the kidney, which eventually results in increased serum creatinine and progression over the years to the time that we need dialysis or transplant. Our endocrinologists are doing a great job, so we get to see less and less patients, yet 20 to 30% of the population of patients with diabetes, type 1 or type 2, still develop diabetic nephropathy. So we really need to work together to actually prevent complications from happening. Thank you, Tony.
Dr. Fernoni, thank you. Dr. Levine, we welcome you. We have a question that was submitted earlier this week. It goes, what can I do to prevent diabetic foot complications?
Sure. So thank you very, very much. And that is a great question. So first and foremost, so it is to control your blood sugar. That is, it is imperative to prevent diabetic foot complications that we control our blood sugar. And then number two, it is to never walk without shoes. We should make sure that no matter where we are, that we are wearing shoes, because that is our first line of defense against stepping on something and preventing complications. And lastly, it is to check your feet literally every single day. And what you are looking for, it is basically anything that does not look right. So red, hot, swelling, a wound, and a callus. So if you see anything, that's when you need to reach out to your physician so that they can be managed right away.
Dr. Levine, thank you.
Pleasure.
Dr. Townsend, welcome. What are my chances of developing eye problems from diabetes?
Well, thank you all for having me here. You know, the chances of developing eye problems from diabetes really depend on how long you've had diabetes, as well as how your sugar has been controlled, how well it's been controlled. I mean, as a ballpark number, a third of American adults with diabetes have some sort of diabetic retinopathy or diabetic eye disease, and 5% have vision loss from diabetes. So, you know, when you look at the total number of American adults and worldwide adults with diabetes, it's a huge number of people. But it goes back to the duration of diabetes, as well as the long-term sugar control.
Dr. Townsend, thank you. Dr. Mizrahi, we have two questions within one here. What tests are used to diagnose diabetes and pre-diabetes, and which tests help my healthcare professional know what kind of diabetes I have?
This is such a key question because before we always look at only fasting glucose to make the diagnosis of diabetes, which is still valid, but that means that you will have to fast overnight and then get your blood sugar check in the morning. And this is not blood check by your neighbor glucometer. It's just you need to go to the lab and have your glucose check in the fasting state. But now it is accepted that we can just check or screen for diabetes using the hemoglobin A1C. And this is another blood sample. This is a very easy and simple test to do. And finally, another test that is done less frequently is a glucose tolerance test, where an individual comes to the lab, he has to, or she has to drink some sugary drink, and then they will measure the glucose after that. We do less and less this type of test. Now, in terms of what tests to use to classify the kind of diabetes, I think this is very important because there are two types of diabetes, the type 1 and the type 2. And initially, we thought that the type 1 were the young ones and the type 2 were the old ones that would have some obesity issues. But now we know that there's a big mix between type 1 and type 2. And that's why it's always important when we see patients with type 2 that we suspect if there is any signs of type 1 diabetes, and we need to check blood tests for looking at what we call antibodies. And those antibodies are the ones that in type 1 diabetes destroy the insulin producing cells. So all those tests together with measuring the insulin levels will help us to define if somebody has type 1 or type 2 diabetes.
Dr. Mizrahi, thank you. Dr. Perlman, Are fruits bad if I have problems with my blood sugars? And if not, which fruits are better for me to eat?
So fruits contain natural sugars like fructose. And although they contain sugars, fruits also contain very vital nutrients, including vitamins and minerals and dietary fiber, as well as antioxidants. And they're all so incredibly important for immune function and for our microbiome. So the little kind of bacteria that inhabit our gut that really help promote our overall health. The issue really is that this big banana right here, as you can see the numbers, people often say they had one banana when in fact they had 3 servings of a banana. And this is the typical size banana you're going to get at a grocery store. So just like one raspberry does not mean one serving and one watermelon does not mean one serving, one banana often does not mean one serving either. So although fruit is very important for our overall health, a lot of people look on social media and they're told, cut out the carbs, cut out the fruit, that's what's causing your diabetes, and that's very far from the truth. The issue is that people don't just have one serving of fruit, they have an entire fruit bowl with 5 different fruits. The other issue is we go to kind of the new trendy juice place on the corner or the smoothie place, and all of these places say, we put organic fruit in there, it's all natural, it's hormone free, non-GMO, there's no added sugar. So we say, hell, I want to be healthy, I'm going to get the 64 ounce instead of the 8 ounce juice, right? How many of you have done that? And so they end up getting an extra large drink because we think that more is better. And then we wonder why we're gaining weight or our blood sugars are out of control. And it's because they're not lying to you. They were honest when they said there's no added sugar and that it's organic and that it's hormone free. But what they didn't tell you was that although they didn't add raw sugar packets, they added 2 mangoes, a pineapple, 3 apples, and a little bit of honey and agave on top. And what does that mean? Although it's all natural sugar, some of these green juices or smoothies actually give you a whopping 80 grams of sugar just in that one juice or smoothie.
Wow. Wow. That puts it in perspective right there. Thank you, Dr. Perlman. Dr. Garg, I've heard that once you start taking insulin, it is a terminal stage. Insulin causes damage to organs and you can never come off insulin. Is this true?
This is not true. So another myth. Insulin is not harmful. There are a lot of misconceptions about insulin, and that leads to hesitancy among patients as well as among providers, actually, your doctors, that insulin is bad, it should not be given. It's not the insulin, it's the blood sugar that's going to do the damage. The higher the blood sugar, the more the damage is going to happen. So if you need insulin, that's the treatment. You have exhausted all other options. It's an injection, but you should take it. The important thing is to correct your sugars. Now, if you start on insulin and then you lose weight, you change your lifestyle, it is possible that you may not need it. So it's not that once you start it, it's permanent. We do see that we start it and then the patient changes their lifestyle, they stop eating all those fruits that Dr. Perlman mentioned, smoothies, juices. There are a lot of people who drink a lot of sugary drinks. And so they stop that and then they may not need insulin anymore. So I just want to make it clear, insulin is not bad for your health. If you need it, it's important to accept it, to take it. And it's not for sure, it's not permanent. It's in type 2 diabetes. In type 1 diabetes, they have to have it for life. You're on mute, Tony.
Doctor, thank you very much. Dr. Fernoni, if I do develop diabetic nephropathy, what is my probability to end up on dialysis or to need a kidney transplant?
Thank you, Tony. That's actually the most typical question from a patient coming to see a nephrologist now, because there is the fear factor of this transplant or dialysis coming down the road. There are very good data showing that the yearly probability to progress from one stage or the other of kidney disease is approximately 2% per year. However, what I really want to mention is that one of the reasons why diabetic kidney disease is a problem is not only because it put you at risk to reach dialysis or transplant, but it actually increased the probability to die from a heart attack or a stroke, to the point that once you actually start leaking this albumin in the urine, as I mentioned before, actually the chance to die from a heart attack or a stroke is 20% in 1 year, while the chance to just progress to the next stage of kidney disease remain 2 to 3% per year. So really thinking and stressing the importance to identify the disease at the very early stage of disease so we can treat it. Sometimes I discuss with my patients, I wish diabetic kidney disease would be painful, because if it would be painful, you would come to see more often and you would actually seek attention. The problem is that this diabetes is almost like a Pac-Man effect, eating up your kidneys without really causing any pain. So it's only your awareness and you're working in the team with your doctors, your endocrinologists, that really would allow us to provide the proper care and make sure that you can monitor on a yearly basis for diabetic kidney disease.
Very descriptive, Dr. Fornoni. Thank you so much. Dr. Mizrahi, we just had this sent in to us. It goes like this. Both of my parents are type 2. 3 of 6 children are type 2. Are there certain predispositions for one child to become diabetic versus the other child?
So this is such an important question, because put in perspective most of what we see every day. And as was mentioned before, individuals are born with a genetic predisposition, and type 2 diabetes has a very important genetic component. We still don't understand what are the genetic basis of diabetes, because there are multiple genes that in a mixture can increase the susceptibility to diabetes. Now, when you tell me that there is this strong family history of diabetes, that means that those individuals, due to these genes, will have insulin-producing cells that are defective. And the way that I explain that to the patient is like if you have a car with an engine that has only 2 pistons. So that car will work well, but then if you stress it or you put it on a hill, that car is not going to work. And that hill, what I tell the patients, is your weight. When they start gaining weight, those cells that are defective, don't work properly, and that's when diabetes starts. So now, when you have a very strong family history, one of the key points that you need to follow is avoid weight gain and try to prevent diabetes over the long term. So yes, genetic is a genetic disease, and weight also plays a big role. Now, there is another important point. Depends on what age these patients develop diabetes. There are some other genetic diseases that could be more frequent, and we can talk about, off the line with the patient if they want to. But a strong family history, especially when it's diagnosed in individuals less than 25 years old, has a component of monogenic or one gene disease.
Thank you, Dr. Mizrahi. Dr. Levine, why do diabetics sometimes end up with a foot amputation?
Sure. So that is a great question. So the biggest culprit here, it is from a diabetic neuropathy, and that is numbness of the feet. And the problem with numbness of the feet is that if you step on something and you don't feel it, that can be very problematic, because that can quickly lead to a diabetic foot wound, which if you don't check your feet on a regular basis, then you might not know that it is there, until you might see a bloody footprint. And that's when you will see that there is something not quite right. So it is really important to check your feet on a regular basis, because if there is a wound and you don't feel it, then by the time that you come in to seek treatment, it will be very, very challenging to treat it without an amputation. So prevention in this case, it is certainly the best treatment. So check your feet as much as you possibly can.
Thank you, Dr. Levine. Dr. Townsend, how do I know if diabetes is affecting my eyes?
So a lot of diabetic eye disease is sort of analogous to what Dr. Fernoni was saying about diabetic kidney disease. You know, it's a slow onset, and initially you don't know anything is wrong. So there are screening guidelines. For example, with patients with type 2 diabetes, upon diagnosis, they should get a comprehensive full eye exam with special attention to the back of the eye. So dilating the pupils and looking at the back of the eye and the retina for any signs of diabetic damage. And then even if there's no damage, still you should get your eyes checked once a year. It's rare. It does happen that patients actually would know something's going on with their eyes. They would see visual fluctuations early on in the disease course. But for the vast majority of people, you don't know the diabetic, that you don't know that diabetic retinopathy is coming on until it's already in a pretty severe stage. So regular screening exams with an eye doctor, fully dilated. You know, a lot of times we can go to the eye doctor and they'll might ask you if you want to be dilated or not, because it's kind of inconvenient to go around dilated all the rest of the day. But if you're diabetic, you need to get your eyes dilated once a year and checked. And then if problems develop, then we get into the treatment, and that's sort of a different discussion.
Thank you, Dr. Townsend. And I'm sure a lot of people were nodding their heads when you said, when doctors ask about dilation, you keep going, no, it's a little inconvenient, but I thank you for that. Dr. Mizrahi, we're going to come back to you. Can I reverse my diabetes? And is diabetes ever curable through a healthy diet and weight loss? I think we've addressed this a little bit tonight, but I think if you can kind of go into this a little bit further, that would be great.
So let's start with the first question. Can I reverse my diabetes? And the answer is yes. So as Dr. Garg and Dr. Perlman had mentioned, in individuals with type 2 diabetes, if you lose weight, that decreasing weight is going to decrease what we call your insulin resistance. And those beta cells that I told you, the insulin producing cells that are defective, can work better. So yes, you can reverse your diabetes temporarily, but that defect stays. And if you gain weight back, then this defect is going to manifest again. Now, is diabetes ever curable through a healthy diet and weight loss? I would say that that's kind of a similar answer. I mean, when we talk healthy diet and weight loss is equivalent to decreasing insulin resistance and also help those beta cells or insulin producing cells to work better. So I think the answer to reverse, yes. To cure, probably not.
Dr. Mizrahi. Dr. Perlman, another magic bullet question here. What are some low calorie, low sugar meal or snack options that I can have?
Yes, so I just want to kind of talk first about salt and sugar. Salt and sugar are, well, they give me job security again. They improve the palatability of food, hence why they're frequently used in really everything that's processed. When you go to a bar, what do they have at the bar? They have salted nuts. What does that do? It quenches your thirst, so you drink more alcohol, and then you eat more nuts, and then it's just a vicious cycle, and then you have a huge bar tab. So processed foods often contain a lot of sodium and a lot of sugar. And the sugar in particular is often high fructose corn syrup because it's cheaper than regular sugar and it's actually sweeter than regular sugar. And it's in everything. And so if you're looking for snacks that have low sodium or salt and low sugar or no added sugar, I got some great options for you all. I am a huge fan of snack packs because I know myself, if I have a huge jar of peanut butter at home, I'll probably eat half of it. So you have to portion control. Too much of a good thing can still be a bad thing. So they have like these 100-calorie snack packs of nuts. I get them non-roasted and unsalted. So these are just almonds and walnuts. Another great option are having things like Greek yogurt, not the ones that are flavored. The flavored yogurts often have a ton of sugar. If you get Yoplait, and I hope Yoplait doesn't come after me, they often have over 20 grams of sugar per one little serving. So what I usually tell people is usually go for a Greek yogurt. Don't be worried, all my lactose intolerance folks. There's very little lactose in the Greek yogurt. So if you have a Greek yogurt, it has about 16 grams of protein, which is very important for diabetics and really the general population. This one in particular, the plain, has about 5 grams of sugar. So if the Greek yogurt tastes very bitter to you, then you can add the nuts to it, and then you could add 1/3 of this whopping banana. So you have your fresh fruit with your natural sugar, you have great poly and monounsaturated fats in the nuts, and then you get your protein, calcium, and probiotics in your yogurt. It's a big go-to. And then other quick options here, these little 100-calorie snack packs of almond butter, no sodium and no sugar added, very easy. 100-calorie snack packs of oatmeal. And then these are super easy, these little tuna packs. So on the go, if you're traveling, if you're at work, you don't get a lunch break, these are all quick and easy, very healthy options. And particularly for diabetics, they are low in sugar and really don't have much added sugar.
I'm glad you mentioned that jar of peanut butter, because I'd be the one who would certainly go into that. But listen, we have a follow-up here, Dr. Perlman, that was just sent in. How do you get people with a lifetime of bad habits to change their bad habits, their eating habits?
You know, the hardest part about my job, Tony, is teaching a grown adult that what they learned were normal eating behaviors is actually very far from normal. And what we think, what we grew up as, you know, if your stomach's upset, you have to have ginger ale and saltines, or you have to be part of the clean plate club. Unfortunately, all of those quote unquote normal eating behaviors are making us ill. And so it's really about meeting the patient where they are and not making them feel embarrassed. It is hard enough for an adult to show up to my clinic and admit that they have a problem and they need help. So the last thing I want to do is make someone feel guilty for gaining 50 to 100 pounds during, let's say, the COVID situation. So it's about understanding their goals. What are their fears? What are their current circumstances? What do they hope to get out of the visit with me? Why have they not been successful in the past? And what sort of resources and help do they need now in order to be successful moving forward? I approach it as a partnership. I am their cheerleader. I am rooting them every step of the way, and I support them through the process and really try to minimize that guilt and embarrassment that they often have.
That was great, Dr. Perlman. Thank you. Dr. Garg, we just had this sent into us. Recent studies have shown that metformin can settle in the salivary glands and leave a bitter taste. Is there an alternative to metformin that doesn't do that?
I don't really know the answer. I haven't seen that study, that metformin settling in salivary glands. There are plenty of medications that we use these days. Metformin is one of them, first-line treatment. But I'm not aware of this study and if there is an alternative. Dr. Mizrahi, do you?
No, but certainly metformin is one of the most commonly used antidiabetics. But if there is any adverse event from metformin, there are multiple other options for the treatment of diabetes, not only similar to metformin, but also working with different mechanisms.
So one of the things I would like to say, our principle in type 2 diabetes management is the patient has to be comfortable with it. There are at least 10 different classes of medications that are available. So if you are having side effect with one medication, we don't want to push that you keep using. My threshold for stopping metformin is pretty low. It's not that if you are getting diarrhea, or diarrhea is the commonest side effect of metformin, or some other side effect, or simply you don't like to swallow the pill. We will find something that suits you, your lifestyle. So it's important that you're comfortable with what you're doing, because it's a long-term treatment, and it's extremely important that, again, this is a partnership, that you like doing, or you can do what we are asking you to do without too much of a trouble.
Thank you, Dr. Garg. Dr. Fornoni, are diabetes drugs available different in a way that they can protect kidney function and delay dialysis?
Thank you, Tony. That's actually an excellent and very up-to-date question. We used to send our patient to the endocrinologist saying, oh, just get that blood sugar down to this level or the A1C down to this level. But lately, I think the question is, if I bring down the blood sugar to a given level, does it make the difference to my kidney if I do it with one drug versus another? And there's a series of drugs that have been developed in the past few years that actually show that even if we achieve the same blood sugar target, they can actually protect the kidney much better and much longer. So by dialysis-free time is something that it's something they can provide. So I would really just want to encourage you, without really describing the specific drugs, when you are trying to achieve a better blood sugar control and you do know that you have diabetic kidney disease, ask your endocrinologist, ask your primary care doctor, but these drugs also protect, is this drug the one that protect me the kidney the most, because the data are out there now and it's exciting. We had nothing from the 90s and we have now new drugs that protect the kidney, and stay tuned. We have invented new drugs at the University of Miami that actually are likely to protect the kidney even further, and they are being FDA approved to move forward in clinical trials.
That was a nice tease. That was we will definitely stay tuned, Dr. Fornoni. Thank you for that. Dr. Levine, how should I care for my feet on a daily basis to prevent complications?
Sure. So the most important thing, it is to protect your feet, and on a daily basis, that's going to be, it will be wearing shoes that fit you properly. So that is shoes with a fairly comfortable toe box, so that your toes aren't tight and crammed up in there. Plus, it will be to check your feet and to have a physician check your feet on a yearly basis. So make sure that your physician, whether that be the podiatrist, or your primary care doctor, that they are checking your feet at least once a year, and if there is any problems, that you get it cared for quickly, and do not wait to see if it will get better without treatment, and if it is something that you can take care of yourself. It is really important to come in as quickly as you possibly can.
Thank you, Dr. Levine. Dr. Townsend, if I go to the eye doctor and they find diabetes, what can be done?
So we have a whole range of treatments for the eye. In the early stages of diabetic retinopathy, there actually aren't any treatments necessary in your eye. It's usually the mainstay of treatment is trying to improve the glycemic control. You know, for us, we always recommend that you aim for a target of hemoglobin A1C of 7 or less. Now that's really good, and I say aim for, meaning it's a goal. It's not everyone achieves it, but with really good glycemic control, diabetic retinopathy can stop at a level where it doesn't affect your vision and never affects your vision. It can actually even get a little bit better with really good glycemic control. Also, there's some new research now that genetic sequencing and testing for different mutations in someone's genome is fairly easy to do. We're finding that for certain people, taking certain vitamins along with good glycemic control can actually improve the blood flow in your eye and improve the amount of diabetic retinopathy or diabetic eye damage that you have. But when you get in the more advanced stages, then you start to need the retina specialists help. We have lasers that have been around using laser treatments of the eye for 30, 40 years. And then in the last 15 years, injections of a medication into the eye have proven really, really effective in rolling back diabetic retinopathy and maintaining vision. And getting an injection in your eye sounds pretty terrible, but the procedure is done in such a way with a lot of anesthesia that it's not a terrible thing. Patients come back. The drawback to the injections, while they work really well at maintaining vision and keeping the eye healthy, is that they're not permanent. So it's necessary to repeat injections sometimes as frequently as every month. Now, not everybody needs them every month, but it's something that you got to keep coming back for. And when you're a working adult, finding time to go to the eye doctor once a month it's tough. So a lot of factors play in, but a lot of these, as we've said over and over, all the panelists, a lot of things come back to glycemic control, and the better that is, the more luck you're going to have maintaining the health of your eyes and your other organs.
Well said, Dr. Townsend. And you're right. It could kind of make you say, ouch, when you first hear that about an injection in the eye. Thank you so much. Dr. Mizrahi, what does leg pain mean with diabetes?
This is also such an important question. I mean, more commonly, this is secondary to what we call diabetic neuropathy. What that means is that the uncontrolled diabetes in the long term affects the nerves of the both arms and legs. And these by itself can cause numbness, tingling, burning sensation, sharp pains, cramps, and many other symptoms that are important, because those symptoms or signs will tell you that you're at risk of developing other complications. And Dr. Levine has already mentioned all the other complications of the diabetic foot. So all those are consequences of diabetic neuropathy. What it means when you have pain is that your nerves are still alive. And then if you can get into an intensive glucose control over time, you can still ameliorate this pain. And in addition to that, there are other medications. But also, you also should think about other causes of leg pain. And one of those, of course, is muscle issues or joint pain, or in patients with long-term diabetes, you can have what is called claudication, and it's an obstruction of the blood vessel or blood supply to the extremities, and that can also cause pain.
Thank you, Dr. Mizrahi. Dr. Perlman, can you talk about reading labels and the glycemic index?
Absolutely. So I don't know about you all, but I can tell you that never once when I was growing up did anyone sit me down and say, Michelle, this is how you read a nutrition label, and this is how you interpret it, and this is how you use it when you go to the grocery store. Despite all of my years of training, both just kind of learning about nutrition on my own, but even through undergraduate with biology, medical school, residency, and fellowship, it wasn't until I was kind of close to graduation, where I was actually working with an endocrinologist and a weight management specialist in Dallas, that I actually learned how to ask someone, what do they eat on a typical day? So often when people come to me, I'm like their last resort, unfortunately, yet I'm the very first person that has ever asked them, what are they eating? And not just, are you eating a balanced diet? Because we're often asked that question by our primary care doctor. And oftentimes people think that they can get away with, oh, I eat the normal stuff in Miami. It's all about delving into the details and figuring out, okay, are they having coffee? What are they adding to their coffee? Are they adding raw sugar? Are they adding the artificial sweeteners like Splenda, like Equal? Are they adding honey, like a little honey packet? All those things are so important. So really the key thing when you're looking at a nutrition label is looking at how many servings. So just like we spoke about the banana, one banana doesn't equal one serving. Always look on the package to see, is it one serving or is it feeding a family of 5? You want to look at the total calories, the fat, the carbs, and the protein. Now, particularly for diabetics, what is most important? So for diabetics, you definitely want to pay attention to the total carbohydrates the dietary fiber, the sugar, and then the new kid on the block are the added sugars. That was recently updated to the label. So my rule of thumb is that try to stay under 7 grams of sugar per serving. I get the question all the time, Doc, how much sugar do I need? Really, at the end of the day, we don't need to eat any sugar. Why? Because our body turns any excess calories into sugar, meaning if we eat, a whole rotisserie chicken, whatever our body cannot use to break down into amino acids to then help build muscle, basically our body turns into glucose. That's the way it works. And so if we're not burning it off, everything gets converted into sugar. So technically our body does not need to take in extra sugar throughout the day. Now the issue with the glycemic index, which we briefly kind of touched upon earlier, is that we hear it all the time. What is the glycemic index or the glycemic load of a product? The issue is that there are so many variables. So if you have a raw carrot versus a cooked carrot, or depending on the soil it was grown in, or depending on if you had 2 carrots versus 2 bags of carrots, or if you had the carrots with a little pack of guacamole, that all affects your glycemic index. So it's extremely difficult to really interpret that information. And the issue is the glycemic index does not actually correlate or have a good association with your blood sugar. So everyone kind of has a different response to those types of foods.
Interesting. Dr. Perlman, thank you so much. Dr. Garg, I wear a glucose monitor. Sometimes after eating, my glucose spikes as high as 220, but comes down on its own. Is this normal?
So blood sugar will go up after eating, but we try to keep it below 180 if possible. So there are 2 things that we look at during the management of diabetes. One is the hemoglobin A1C. That is the primary measure that we look at. Hemoglobin A1C is a test that tells us about the average of your blood sugars in last 3 months. So if your sugars are high on an average, then your A1C will be high, whether it's after eating or before eating. So the other thing is we look at your blood sugar and we try to keep it after eating below 180 and before eating, if possible, below 130, especially in the morning. So it's normal for blood sugars to go up after eating, but 220 may be too high, especially if your hemoglobin A1C is high. If your A1C still stays below 7, then I will say that's okay, that's acceptable.
Thank you, Dr. Garg. Dr. Levine, is it safe to get a pedicure at a salon if you have diabetes?
Sure. So that is a very good question. So what I would say is that my recommendations for somebody with diabetes and even for somebody without diabetes, is that if you get a pedicure, so number 1 is to make sure that they clip your toenails straight across so that they are not digging into the skin. And number 2, it is to make sure that the equipment, that it is completely sterile. And the best way to make sure of that, it is to see if they are peeling the equipment from a sterile package. And then number 3 is that if you will let them soak your feet, to make sure that that is in a disposable basin. And what I will stress is that if somebody is a high-risk diabetic, so that means that they have neuropathy, or they have any circulation issues, or they are taking they are taking a blood thinner, then they should be seen by me or a podiatrist so that we can clip their toenails for them a safe, sterile environment.
Dr. Levine, thank you. And Dr. Fornoni, for just the last minute or so, this question was sent in. I was diagnosed with diabetes at 55. I'm anemic and have kidney disease. What can I do to improve my health?
So there's obviously once you have established kidney disease, the key part is how to slow the progression, how to retain that percentage function that is left. Diabetes leave like a scar on the kidney. So the goal, once we have a scar left by diabetes, is to preserve the percentage of kidney function over time. And there is no doubt that without having a magic wand or a new drug, controlling your blood sugar, controlling your blood pressure, lifestyle, proper diet, proper care of your feet, and of your eye will actually preserve the kidney as well over time. So I think really these are the key aspects, and that's where it's important to work in a multidisciplinary setting to make sure that together we can make sure that that time, that slope that leads the kidney to need dialysis becomes almost flat and would allow you to live up to 100 years without talking about dialysis or kidney transplant. And if that happens, I think the key part is also to be prepared to try to plan for a kidney transplant before actually getting on dialysis. There is no doubt that what we call preemptive kidney transplant, meaning transplant before dialysis, is actually a better outcome than just going through dialysis and then transplant. And I would like to remind you, there's no age limit. At least we transplant people that have no major comorbidity up to age 80 for kidney transplantations. And I have patients in that age range that go out sailing after a kidney transplant. The key part is that we have solutions we didn't have 50 years ago. So we don't have to be afraid, but we have to work together to make sure that the slope that leads to the need for a dialysis or transplant remain flat. And nothing but controlling your blood pressure and diabetes with the appropriate agents is the way to go.
Thank you, Dr. Fornoni. Wow, this hour has just flown by. And as we close the town hall, that's our last question of the night. We could go on and on for another hour, I'm sure. I would like to ask Dr. Mizrahi for some final thoughts.
You're on mute, Ernesto.
You're muted again, Dr. Mizrahi.
Sorry. Thank you, Tony, for moderating this important discussion, and thanks to all the members of the team who participated here. We appreciate the opportunity to answer your questions, your interest in what we do, and the support of the community. The physicians here today and all of our physicians are among the very best in the world. You already saw that, and we're committed to maintaining a level of excellence, and especially our comprehensive diabetes centers is a key component of that. The enthusiasm you could see, commitment, the expertise reflects all the drive that we need to successfully deliver innovative treatments for type 2 diabetes. As closing, philanthropy helps to ensure that we have the best people and we provide them with the best resources and infrastructure to achieve this. I want to acknowledge the generosity of the Board of Trustees, our leadership, and thank you all of our faculty, staff, and loyal donors. You continue to help us set the standards of care here. You inspire us to go above and beyond. You could see that to find solutions that will make a difference in our patients' life. So thank you for all the times and sharing your expertise, and until next time.
Thank you, Dr. Mizrahi, and thank all of you for participating in tonight's In the Know Town Hall. This really has been an amazing hour. I hope you agree. You know, at the top of this broadcast, we talked about the wow factor with these panelists, with all these doctors. I hope you will agree, because once again, our doctors, at least to me, and Dr. Mizrahi said it as well, it validates their committed passion and their expertise to all of those dealing with type 2 diabetes. Think about it. It's such a true blessing for all of us to have them in our community and an honor to be able to share our time with them tonight. Busy people who took the time to show, as Dr. Mizrahi said, their enthusiasm and their passion for what they do every single day. Please remember that a full recording of this program will be posted online. Look for the link in the coming days. And in a moment, you will see a survey about tonight's town hall on your screen. Please take a minute to submit your feedback. I've taken this survey. It takes less than 30 seconds. What it does, it helps us understand your interest and helps us improve our program. As always, we wish you and your family good health. Stay safe, stay informed, and remember, it's all about the you. Good night, everyone.